Good afternoon, everybody, and thank you for joining the Harley Street Clinic webinar on management of acute coronary syndromes with our interventional cardiology consultant, Dr. Mohssen Chabok. Apologies, we are a couple of minutes late, but thank you for joining. My name is Alice. I'm one of the GP relationship managers here at HCA Healthcare UK, and I'll be chairing today's session for you all. Before I do begin and begin my introduction and handover, we have a couple of housekeeping points to mention. So the session is being recorded and will be shared with you following today's webinar, along with your certificates. We will have a Q&A session, which will be at the end of the talk. So any questions that you have for our consultant today, please pop those in the chat box and I will go through those at the end. So before I hand over, I'll just give a brief introduction to who we are. So HCA Healthcare UK, so we are a leading private healthcare provider with hospitals, specialist clinics and outpatient centres across the UK. We are leading the way very much so in the sector. We are the first private hospital group to carry out many of the cutting edge treatments within the sector, including robotics technology, our investment in clinical trials, which is they're attracting our leading consultants with us. We provide, as you can see on screen, a wide range of acute and elective services in the private sector. Services ranging from IVF, maternity, all the way through to paediatric care, as well as our complex casework, which includes cardiac and thoracic, oncology, neuro rehab, and living donor transplants, just to name a few. In cardiac care alone, in that specialty that we provide, we are a premier destination for our complex heart care. With our network that we have, we've got 15 advanced cardiac diagnostic centres and 5 state-of-the-art cardiac hospitals. We're very unique in the UK. And as I mentioned before, we continue to innovate, first in the UK private sector, and in some cases in Europe with the latest diagnostics. So one to mention is the iron navigational bronchoscopy that we've brought in this year. Through to our surgical offering as well, with our consultants carry out minimally invasive procedures, such as the quadruple bypass that we carry out, as just one of those to mention. We are the only private hospital group as well to have level 3 ICU in every hospital that we have, so it enables our teams to provide the very most complex care in the sector. So if you would like any information on our services, the contact detail number is on the screen, and I will also put my email in the chat box should you have any more questions. But without further ado, I'll do a brief introduction to our consultant, Dr. Mohssen Chabok, that's joined us today. Delighted to have him provide you with an update today. He is an interventional cardiologist serving as a consultant at the Royal Brompton at Hertfordshire Hospitals and also the Hillingdon Hospital NHS Foundation Trust. And he is practicing privately with us, as I mentioned, at the Harley Street Clinic, which is part of HCA Healthcare UK. And without further ado, I'll hand over to Dr. Chabok. Thank you.
That's great. Thank you very much, Alice. Thanks for the opportunity, and it's my pleasure to be here. So if you can kindly share the slides, that would be very helpful. I'm not sure if it is being shared, but yes, fantastic. Thank you very much. So I'm going to talk about the management of acute coronary syndrome, mainly from practical point of view and from an interventionist perspective in terms of what needs to be done and what are the more pragmatic points about patients coming with chest pain throughout their journey until they are discharged from hospital and then they are being managed in the community. So if you can go to next slide, please. Obviously, cardiovascular disease is one of the leading causes of morbidity and mortality, not just in the UK, it's globally, and it's even worse in underdeveloped countries. And ACS, as a manifestation of cardiovascular disease, it's one of the most important one, which is responsible for around 40% of the death related to cardiovascular disease. And chest pain itself is one of the most worrying signs of any cardiac symptom, and it is responsible for a lot of presentations to primary center and primary setting, as well as secondary care through A&E or rapid access chest pain clinic. So as I'm sure you're familiar, we all encounter patients coming with chest pain. Based on our criteria, and I must mention that my presentation is mainly around European Society of Cardiology guideline, which is not that dissimilar to the UK practice, and it is widely adopted in terms of how we manage cardiac patients in the UK. It is expected that chest pain is described as cardiac, which is a typical chest pain textbook definition, that someone comes with left-sided pressure type, and it comes on exertion, goes away by rest, and it might be associated with some radiation into left arm or radiation into the back or neck or jaw. So this is the typical cardiac angina that we describe. But as we know, it's not always typical to have that presentation. So if you are going to use the right terminology for other presentations of the chest pain that we are not 100% sure it is cardiac, then we should use the term possibly cardiac or likely non-cardiac. And this is important because even based on NICE guidelines, how we're going to investigate would very much depend on how we describe the chest pain. If it is non-cardiac chest pain, we are not mandated to investigate for possible coronary artery disease, if we truly believe it is non-cardiac. But if someone is possibly cardiac or typical cardiac, then there would be a different approach. And also, we should always bear in mind that it's not just the chest pain itself. And in particular, around pain, I always come across difficulties that certain patients, even coming with a STEMI, and they don't want to call it chest pain. They would like to call it chest tightness, discomfort, or ache, or bruising. But ultimately, I usually try to educate patients, saying for us, it's all on the same umbrella as chest pain. I mean, of course, if you want to describe it in a different way, but it is same broad umbrella of chest pain. And we do have some other conditions which are equivalent to angina and chest pain, and that could be dyspnea, shortness of breath. It could be epigastric pain, which is not uncommon, in particular in the context of inferior ischemia. And also sometimes it just manifests as a pain in the left or right arm or neck or jaw. So there are different ways that chest pain can represent essentially, and we need to bear that in mind as well. In terms of physical examination of someone coming in the primary setting or in the first visit, we try just to look at all pulses, and it is relevant when it comes to differentials, which I will cover in the next slide. So we will go through it, that it is relevant to find and to investigate and make sure we are not missing something else, because chest pain, whilst majority of the cases it is cardiac, but there are many non-cardiac related reasons for chest pain, and even within the cardiac remit, I mean, there are non-coronary causes of chest pain as well. So it is very relevant to check blood pressure in both arms in particular, because that would give us an idea about the blood pressure and hypertension itself, and also if there is any suspicion of dissection. And listening to the heart is very relevant. Again, it's something simple. Perhaps since COVID, it's not as common, in particular with virtual clinics, but it's still very relevant. And you would be surprised the number of people coming with chest pain to rapid access chest pain clinic, and first thing that you put your stethoscope and there is a loud systolic murmur which has been missed, or indeed other interesting cases which I will mention as we go. And we need to again check for signs of heart failure and any signs of compromise, because again it would be relevant in terms of the differentials. Next slide, please. So here I would like to talk about differential diagnosis of acute chest pain, and there are different categories, obviously, as we discussed. So from cardiac point of view, differential to acute coronary syndrome or coronary artery disease causing chest pain, it could be myocarditis or myopericarditis, or indeed cardiomyopathies like hypertrophic cardiomyopathy that could give chest pain. Tachyarrhythmias, they can be responsible for chest pain, in particular, I mean, in any age. And I usually use the example that heart is a muscle, and like any other muscle, if you exercise it enough, And if you go on a treadmill for 2 hours, obviously, like any other muscle, it will be tired and it will start aching. And heart muscle is not an exception. So if it goes false for long enough, then it will start aching, and that could cause chest pain. And in the similar fashion, we can have in the context of acute heart failure, we can have chest pain, hypertensive emergencies. They are not uncommon, and they can cause chest pain as well. And aortic valve stenosis, of course, AS can cause chest pain as well. There are some other syndromes which is less prevalent, but Takotsubo or coronary spasm in particular, and cardiac trauma, which is mainly responsible for RV injury, they can give chest pain as well. And when it comes to non-cardiac, obviously pulmonary and PE, pulmonary emboli, is one of the most common causes of chest pain. Tension pneumothorax, I mean, I had the patient who came to see me privately and with chest pain, and as soon as I again listened to the lungs, it was unfortunately a tension pneumothorax, and they do manifest in the similar fashion, discomfort. And bronchitis or pneumonia, depending on the location, it could manifest as a chest pain, and if it happens to be in the left lung, then it is even more worrying. And pleuritis, of course. In terms of vascular, I mean, again, aortic dissection can give a similar presentation, symptomatic aortic aneurysm or a stroke. And GI is another one which is not infrequent, that we see patients with reflux or with a spasm, esophageal spasm, or gastritis or pancreatitis, or indeed cholecystitis, and they could manifest as chest pain, and vice versa indeed. There are orthopedic conditions such as musculoskeletal or chest trauma, and some other rare causes such as anxiety disorders or herpes or anemia. But for the last two categories, they are usually diagnoses of exclusion. So we try to investigate for other things. And then if you don't find anything, then I would perhaps settle, in particular, when it comes to anxiety and musculoskeletal, I will try to investigate first before reaching that conclusion and diagnosis. Next slide, please. So assuming that someone has acute coronary syndrome, it is a broader spectrum of presentations, and essentially it can be seen as recent change in the sign and symptoms, or it could be with or without ECG changes, and it could be with or without troponin rise. So as we can see, it is really a broader spectrum. It could be someone with completely normal ECG, no blood marker, and still having coronary artery disease, or it could be as bad as someone who is coming with very typical angina symptoms. ECG shows a elevation, and of course the troponin is going to be positive. So the first presentation, which is the start of the spectrum, it could be unstable angina, and that's where it could be slightly tricky. And we describe it as a prolonged chest pain, which is more than 20 minutes. It could be at rest, or it could be on exertion in a predictable fashion, or it could be manifested by increasing in frequency or intensity, and it goes longer before it resolves. And in some occasions, there might be lower threshold. If someone is having a stable angina, they usually experience it after half an hour of exercise or walking. And then if it becomes after 20 minutes or 10 minutes, then it's another sign of unstable angina. And if angina occurs after recent episodes of MI, then again, it is an indication of unstable angina. And this is the condition that you could have potentially normal looking ECG at rest with negative troponin. But again, based on risk profiling patient and the presentation, then we will decide on the level of suspicion and then whether or not to investigate further. Acute MI is in a way easier, and it is described by rise and fall in the troponin. So that's extremely crucial to see that in acute myocardial infarction. And there are different types of MI, and the latest definition has changed from type 1 to type 5. Previously, it was mainly type 1 and type 2, but now we've got up to type 5 that I will touch base on, and then we can talk about it. And also there is a new category and definition, which is called myocyte injury or myocardial injury, which is in the context of having positive troponin without evidence of ischemia. And that could be related to different presentations such as sepsis, myocarditis, or heart failure and arrhythmias. Next slide, please. So with regards to type 1 MI, I already mentioned that it is rise and and fall in the troponin. So we need to see the peak troponin, and also that peak troponin could be different according to patient age or renal dysfunction, and also the time of the chest pain onset, because it will start peaking a few hours after the MI and then until 2 to 3 days post the MI, and then even reach a peak before starting the downtrend. And depending on the gender, it can be different as well. And generally speaking, it is recommended to consider 0 and 1 hour algorithm, which is the best option. And we do have high sensitivity troponin, which allows us to do that in acute settings in the A&E. If someone has chest pain, we can potentially do first on arrival and then another one in 1 hour. And the negative predictive value is 99%, which is quite significantly high, and we can safely discharge patients still with safety netting. And the ruling would be around 70 to 75% positive predictive value that we need to admit patient and then do further investigations. Next slide, please. So in terms of acute MI classification, if someone is confirmed to have MI, which is defined as positive troponin, so type 1 would be a spontaneous MI. It means there is a plaque rupture in the coronary artery, causing narrowing in the artery, and then as a result of that, there is myocyte injury and release of troponin, which peaks, and then it will start downtrending. Type 2 MI is usually related to supply and demand balance in the cardiac cycle. So, and it could be related either to higher demand or lower supply, such as severe anemia or low blood pressure or significant bradycardia, which is lower supply, or higher demand, such as sepsis or other different conditions, which can, systemic condition, which can cause that imbalance. So that would cause type 2 MI. And type 3 MI is the MI that we essentially don't know if someone has suspicion of, for example, cardiac VFRS, and they die and we don't have any troponin results, then it would go on the type 3. And then if post-mortem it is confirmed, then we can reclassify that. Type 4 and type 4 are related to procedures. So type 4 related to PCI, and type 5 is related to bypass MI. Next, please. So the most important one, which is not uncommon, in particular these days, anyone coming through the doors of hospital, we will see that troponin is in a way as common as doing full blood count for patients. So it's a routine test, and in a lot of presentations, you will see that troponin is either marginally or significantly positive, and it's not always type 1 MI, or indeed it's not MI at all. It could be just acute myocyte injury. And there are a couple of examples which I've listed, and it is nicely on the different headings in this table that we can go through. So reduced myocardial perfusion could be such as coronary artery spasm, which is temporary, and microvascular dysfunction. It could be coronary emboli, in particular in patients who are with AF and they are not anticoagulated. That's one risk factor. Or if someone had MI and they have LV clots, which is again untreated, they could end up having coronary emboli. And again, if there is any non-atherosclerotic coronary artery dissection, that's another differential, or bradyarrhythmias, hypotension or shock, which is as a result of hypoperfusion, respiratory failure, and severe anemia. And then in terms of increased myocardial oxygen demand, obviously sustained tachyarrhythmias, as we discussed earlier. So if it goes long enough, it could cause some upset for the myocardium. And severe hypertension with or without LV hypertrophy, again, that could cause type 2 MI. And there are some other causes of myocardial injury, which is like cardiac conditions such as heart failure, myocarditis, Takotsubo, and some other recent procedure that we discussed. Systemic conditions, the most common one is sepsis and infection, pneumonia, UTI, or indeed any other septic patient. They usually have higher demand, and that could cause some upset for myocardium. And then patients with CKD, they tend to have even chronic myocyte injury, and it's not uncommon to see patients having positive troponin all the time, which is usually persistent, and you don't necessarily see a peak. And some other rare causes, such as subarachnoid hemorrhage and PE with right heart strain, that could give you positive troponin as well. So next slide, please. So we're going to look at the spectrum of acute coronary syndrome. So we are assuming that we are dealing with a patient which has coronary cause for the chest pain. And in terms of the manifestation and presentation, it could be just walking in, normal ECG as we discussed, or it could be as bad as arresting in the community with VF or VT indeed, or and having a STEMI on the ECG. So that's the spectrum. And depending on how they manifest and how they present, we will investigate accordingly. And there are different ways of dealing with it. So this is a cardiology talk. We have to have some ECGs, and I thought it's relevant to just look at some ST elevation ECGs, and these are good examples that obviously, can we go to the next slide, please? So, thank you. So these are some good examples of the conditions that, or different types of MI that you will see ECG presentation, and it's very important to recognize them early because time is muscle, it's cardiac muscle, and the sooner we can identify and the sooner we can act on it, obviously the better. So first one is an example of ST elevation in a STEMI, which is usually suggestive of total occlusion of the artery. And second ECG that we are looking at, it is an example of a posterior ST elevation, which we usually see in a way of ST depression in V1 to V3, and the easy way to identify that is by flipping ECG and looking at it. You will see ST elevation in the same leads, and that is suggestive of posterior STEMI, and that's the one which is missed by far the most because it's not obvious, and circumflex on its own has an odd presentation usually compared to the other arteries, and then ECG could be completely non-specific or just ST depression, or it can be mistaken for ST depression. So it's very important to always have that bear in mind, in particular if someone has ongoing chest pain, we need to bear that in mind. ST depression, which is in a shape that we see, and by flipping ECG, you will see clear ST elevation. And then if we do have obviously inferior ST elevation, or if we can capture ST elevation in our V7 to V9, which are the extended leads going around, or indeed, if you go over RV, then we can capture that ST elevation, and that's usually indication of RV infarction, which is very likely related to right coronary artery or a dominant left circumflex. The other thing which is very relevant is if there is a widespread ST depression, or if there is a ST elevation in AVR, that on its own is an indication of either left main narrowing or equivalent to left main disease, which means 3-vessel coronary artery disease, and all 3-vessel being severe. So that's very relevant. And again, patient with cardiac sounding chest pain, if you're worried about the risk profile, and if there is such a manifestation on the ECG, I would take it seriously unless proven otherwise. And then it comes to our good old left bundle and right bundle, which we usually have, argument about. If obviously they are known and pre-existing, then I would be a bit more relaxed. But if they are not known about, and if someone is coming with chest pain with either left bundle or right bundle, I would treat it same way. So I would treat it as an emergency unless proven otherwise. There's no harm in sending patient to a heart attack center, and we can do a quick assessment if we need to send them away, or send them away from cath lab and admit them, do some blood tests. That's absolutely fine. It's better to do that as opposed to missing someone with a new presentation. Next slide, please. So here we are looking at some examples of non-ST elevation MI, which could manifest as usually ST depression or T-wave inversion. So for example, the first ECG, it's related to leads 1 to an AVL, or if you see, if you go based on different categories on the ECG, your inferior leads are 2-3 AVF, and if there is a true coronary involvement, we usually see ECG changes in different pattern relating to that ECG lead. So 2-3 AVF inferior, and 1 an AVL, it's usually lateral, which could be OIM left circumflex, and then anterior and anterolateral, or V1 to V6, which is often LAD diagonal, or if it is V5, V6 only, it could be either diagonal or again left circumflex, which goes all the way to the lateral wall. So it's always good to have that in mind. And if you are interpreting ECG, just go based on those different categories that we try to interpret. So we can see on the second ECG, we can see example of SC depression, which is, for example, if it is in more than one lead, and in particular, if it is going with the category of one particular artery, then I would take it seriously. And then if there is any transient ST elevation, again, I would personally take it very seriously, because it probably suggests that there is a 99% narrowing in the artery, which keeps blocking and opening. And they are at least very high risk cases that they need to be dealt with very promptly. And then we've got the Valence syndrome, which is a broader spectrum of ECG, mainly related to LAD. If LAD is at risk, and if it is critically narrowed, then it could manifest as a biphasic anterior T wave, or it could be a peaked anterior T wave, which is asymmetrical, or it could be a deep T wave inversion. So that's another important one, which is usually LAD at risk, and that needs to be taken seriously too. Can we go to next slide, please? So in terms of what to do with someone attending with chest pain, so obviously more importantly, after physical examination, quick examination, we need to consider ECG, because that would determine how quickly we're going to act, and it would help us with our direction of travel. And then we need to go through the history, the risk profile, do quick vital signs if someone is in cardiogenic shock or otherwise, or if they are in hypertension emergency, it's good to know. And then obviously, if you have enough time to do troponin, then that would be very relevant. But if there are signs of obvious ST elevation on the ECG, then we don't need to wait for anything. There is a primary pathway, thankfully, all across the UK, and ambulance usually goes to the nearest heart attack center. And the aim is to open the artery within 120 minutes. We call it door to balloon. That essentially in some of the centers, including, for example, Harefield Hospital that I'm based at, it is one of the shortest one in the UK. That's thankfully we can get patients through the door as quickly as possible, try to open the artery. And the sooner we can do that, the more myocardium that you can salvage essentially, and hopefully better outcome for the patient. And then if there are non-ST elevation ACS, then we need to risk stratify those patients depending on their ECG, depending on their symptoms, whether they have ongoing chest pain or not. And if they have any hemodynamic compromise, we'll make a decision how to deal with them. So if there is very high risk of ACS with ongoing angina, or if someone has to be on GTN infusion in order to get on top of the symptoms, then it is pretty much similar to STEMI and needs to be dealt with as soon as possible. But if it's not as bad, then the recommendation would be coronary investigation within 24 hours and revascularization as necessary. And then during the same hospital admission, ideally you would like to have an echocardiogram to look at LV function, to rule out any mechanical complications of MI. And also we need to consider some other imaging during the procedure if there is any concern about potential dissection or otherwise. Then depending on the how the case is presented or what you find on your invasive angiogram, we'll make a decision usually on the spot if we need to investigate any further. And after PCR or bypass or medical therapy, indeed, there are different options available for patients. Then it becomes very relevant how to manage patient long term. So one is hospital stay, admission to hospital, doing the right thing in terms of revascularization, but more importantly would be the first few months post-event and the long-term management in the community, which mainly lies in your capable hands, and you will be dealing with those patients. So can we go to next slide, please? So just touch basing on the diagnostic tools, I thought it's relevant just to go through it, because sometimes there might be a bit of confusion about the role of different modalities. So we should always bear in mind alternative conditions, such as, for example, AF. It's not uncommon. Many elderly patients may come with AF with rapid ventricular response, or if someone has severe anemia, or if they come with hypertension crisis, then these are valid differentials, and we need to bear that in mind. And obviously, if someone is, again, coming with ACS, echo could be helpful if you're not 100% sure if there is any evidence of hyperkinesia. That's usually helpful. And adopting CTCA as the first line is not recommended. And if you are worried enough about someone with positive troponin, then invasive angiography would be the way forward. And MRI has a role to play, but again, it depends on presentation and whether or not patient is safe to have MRI. But it's usually after angiogram. If angiogram is done and we don't find any obvious reason, then we consider MRI to investigate for possible causes, such as if there is myocarditis or otherwise. Can we go to next slide, please? So we already touched base on ACS management. In the community, the first few minutes that we deal with the patient or ambulance arrival, we only give oxygen if saturation is less than 90%. If it is 90 plus, then we try to discourage giving oxygen. But sublingual nitrate, if it's not contraindicated, it's usually very helpful. And morphine is, again, very helpful in terms of getting on top of the symptoms, and it can decrease the preload and negative inotropy and coronotropy. So it's usually will result in lower O2 consumption, which is helpful. And then as a side effect of it, you will have slightly lower GI absorption for dual antiplatelets, but on balance, I think it's good to have a stable patient when you're going to do an invasive angiogram for them. And then IV beta blockers, we don't use it routinely, so it doesn't have any role in our common practice unless there is another reason to use beta blockers. In terms of invasive procedure, we touch base on primary PCI within 120 minutes of ECG-based diagnosis, and then medical therapy, and obviously depending on the degree of ACS, we can decide early invasive if necessary. So next slide, please. So when it comes to dual antiplatelets, obviously we have different options in terms of dual antiplatelets, and this is a diagram which is a bit busy looking, so I do apologize, but it just illustrates different medications and the way that they interact and the way that they work. So you will hear P2Y12 inhibitors, and these are the medications including clopidogrel, ticagrelor, prasugrel, and cangrelor, and obviously good old aspirin as one antiplatelet. And I'm sure you have come across and you have patients with ACS who are on DOACs as well, which is not uncommon, and it's good to be familiar in terms of how to combine it together. And then in acute phases, if someone comes with high ischemic burden, then we consider GP2B, 3A glycoprotein inhibitors such as thyrophylline, which is the main agent currently in the UK. All right, let's go to the next slide. So for our antiplatelets, we consider loading aspirin as soon as possible. It's usually done very promptly in the community. It can be instructed by ambulance services, by 999 call handlers or ambulance as soon as they arrive. And then depending on the ambulance in the area, some will have P2Y12 inhibitor and they load patient even before they get to heart attack center, or some don't. And as soon as they arrive, we usually, if we have the highest index of suspicion that it is a STEMI or high risk ACS, we load them and then we do the procedure. And the first line and the first choice is usually the stronger P2Y12 inhibitors, namely ticagrelor or prasugrel. But clopidogrel is a good agent. It's a safe agent. In particular, I use it for those people who are frail, at high bleeding risk, or if they are over 70 years of age, then you can perhaps just consider something slightly less potent. And it's just the rest is mention of a couple of studies with regards to the combination and slight preference of prasugrel over ticagrelor. But in our common practice, we mainly use ticagrelor as opposed to prasugrel, but both of them are equally good. So next slide, please. So there are different strategies that we need to consider for dual antiplatelets. By default, we consider 12 months of dual antiplatelets for patients with ACS, with positive troponin event, who undergo revascularization, including PCI, or even indeed bypass. but there are conditions that we may have to consider shortening or indeed prolonging the antiplatelets. So it could be as short as 1 month, or indeed it could be the 12 months, or we can cut it between 3 to 6 months. It very much depends on the clinical scenario that we need to make a decision. And the other option is to consider de-escalation of antiplatelets. If someone is on ticagrelor or prasugrel, then we can potentially de-escalate after a month, which is the safe period to de-escalate to clopidogrel. So they will have lower risk of bleeding. If we can go to next slide, please. So on this slide, we can see that different antiplatelet strategies, for example, in high bleeding risk patient. I mean, it all comes to risk-benefit ratio here. It's exactly like patients with atrial fibrillation that we do Chabok and Hasbulled. It's pretty much the same. We don't have the same calculator, but it is just a clinical judgment. What is the risk of bleeding for this patient? What is the ischemic risk for that patient? What's the extent of coronary artery disease? How many stents have I used? What is the length of the stent and the size of the stent that I've used? Have I stented left main stent, for example? So these are the things which will favor longer and a stronger antiplatelet therapy, or indeed if someone is frail and they are at risk of falls and it's just a single coronary artery disease, it's a shorter stent, and the stent is widely expanded, then you can cut it as short as 1 month and then continue with single agent, which can be P2Y12 inhibitor, or it could be aspirin only monotherapy. Next slide, please. There are some occasions that we need to prolong our dual antiplatelet, as I discussed earlier. I mean, if someone has left main PCI, or if they have complex bifurcation PCI with severe diffuse coronary artery disease, in particular for those with diabetes, or if someone has severe ISR stent thrombosis, then it might be an idea to consider prolonged dual antiplatelet therapy. And that is usually based on a Pegasus study that we can consider 1 year of aspirin and ticagrelor 90 milligram twice daily. And after 1 year, we reduce the dose to 60 milligram once daily, but we continue for another 2 years. So total of 3 years of dual antiplatelets. But I wouldn't be surprised if you see the cases that they come on aspirin and clopidogrel lifelong if they have complications, and if it is well tolerated and there is no significant bleeding, then in some occasions we may just continue that lifelong as well. So next slide, please. So I thought it is very important to talk about chest pain in the context of, in particular, alcohol and drug use, because it's not uncommon to see those patients both in the private sector, as well as in the secondary care when they come through ED. So the effects of alcohol on the heart is essentially it's a cardiodepressant, and it leads to hypertension. It can cause arrhythmias. And also, as a result of that, I mean, there are multi-system problems such as subarachnoid hemorrhage. They may have a fall because they are drunk, and as a result of trauma, there might be, as we discussed before, chest trauma and RV injury. There could be evidence of pancreatitis in the context of alcohol. So these are all relevant. And when it comes to drugs, I mean, different drugs will have different effects on heart. So in particular, amphetamines, cocaine, and MDMA, they are chronotropic and vasopressor. So they can increase the demand for myocardium, and as a result of that, they can cause MI. And benzodiazepine, codeine, and opioids like morphine, they are respiratory depressants. So in the same fashion that respiratory failure could cause myocardial upset and injury, this medication can do the same thing. And cannabis, which is not uncommon again, can cause arrhythmia, and to lesser extent, it could cause MI as well. So again, that's something that we need to bear in mind, in particular when we're risk profiling patient. It's very relevant to ask that question and bear that in mind as a significant risk factor, because often patients with that lifestyle, with those illicit drugs, they do get premature and accelerated coronary artery disease. Next slide, please. So when it comes to post-MI care and secondary prevention, it is very important to bear in mind that we need to advocate healthy diet, Mediterranean diet in particular, that's the best one. And cardiac rehab is extremely important, and it's very, very effective and helpful in terms of educating patients, giving them some advice. They usually talk to other patients with heart attack, they learn from each other and they can share experience. It does help a lot with the anxiety, which is not uncommon post MI. And in terms of gaining confidence to go back to daily activity, it is very relevant. Of course, smoking cessation is crucially important, and we need to use the numbers in order to educate patients. So there will be 40% reduction in the risk of another heart attack or death for someone who is a smoker. If they quit, there's 40% reduction. If they don't, obviously their risk is much higher. And I usually say to the patient that obviously stents and bypass grafts, they don't agree with the smoking, and they tend to do much worse. You will get stent ISR or in-stent stenosis, which is blockage in the stent, or indeed the graft will go down. So the other item which is very relevant, and I'm sure it's not uncommon, we always get asked about this, is sexual activity post-MI. So the criteria is climbing 2 flights of stairs. So if someone can climb 2 flights of stairs, it's usually equivalent to the amount of expected energy during sexual intercourse. And if they can do that without being decompensated or experiencing any angina, then by definition, it's safe to have it. And obviously, it is lower risk with a stable partner in a familiar environment, because you don't want too much of excitement, because that won't be very helpful. It would increase the demand on myocardium, and also they need to avoid large meals and alcohol beforehand. So try to do as much as possible in order to minimize any insult to the myocardium. And ultimately, we need to be very careful about the nitrates in those patients, because again, it wouldn't be uncommon for patient with coronary artery disease to be on nitrate as anti-angina, and the combination of anti-angina with medications such as phosphodiesterase 5 inhibitors, sildenafil or tadalafil, is very important. We can give it, but we need to give instruction to patients that they shouldn't use it within 48 hours, because that would result in a profound response. Or indeed, if possible, we should avoid nitrate in the first place, because these days nitrate is not our first choice in terms of anti-angina. We usually reserve it for the cases that we tried other agents, and if they fail, then we use nitrate. In terms of the lipid target, LDL in particular should be less than 1.4 millimole per liter. And that's, again, very relevant, very important. It's good to educate patients and ask them to know the number and then work towards it. So at least they know how far they are, and they would increase the compliance to statin therapy. And total cholesterol less than 4 millimole as a general secondary prevention. And in terms of blood pressure, the ideal and optimal blood pressure for someone with non-coronary artery disease is less than 130 over 80 millimeters mercury. And the HbA1c, we try to keep it less than 53. And if it is anything above that, then we consider medical therapy as necessary. When it comes to beta blockers and ACE inhibitor, I mean, beta blocker is generally recommended for the first 12 months if there is risk of arrhythmia, or if someone has ectopics on their ECG or monitoring, it is relevant. Anything beyond that, beyond 12 months, it would be related to LV function. If someone has completely normal LV function and there is no other arrhythmias in the first 12 months, then that can be discontinued. Beta blocker can be discontinued after 12 months. ACE inhibitor, again, it's usually indicated if someone has coronary artery disease with evidence of CKD or diabetes, or if they are hypertensive, then of course we need to continue long-term. And of course, if they have heart failure, that would be totally different indication for that, so we continue. But if it is uncomplicated MI and there is no other comorbidities and LV is completely normal, then there is no necessarily mandate to carry on long-term. So next slide, please. That would take me to the end of this talk, essentially about ACS management. I try to keep it pragmatic in terms of what is necessary, and I would be happy to answer any questions.
Thank you very much, Dr. Chabok. We have got a question in the chat box, so I'll just read that one out for you. And anyone else that's got any questions, please start popping those in the chat box. We have a question from Dr. Allen. Patient taking, sorry for pronunciation here, clopidogrel for previous TIA, who then has an ACS. Do you change to aspirin long term or continue the clopidogrel?
So if they have been on clopidogrel for another indication, including mini stroke or a stroke, after 12 months, I will keep them on clopidogrel as a monotherapy.
Okay, thank you. Just look and see if there's any more questions for you. And just while we're waiting, if there's any more questions for anybody before we do end for 2 o'clock. If there is any questions that you've got for Dr. Chabok after today, I have popped his practice details in the chat box, but also you've got his QR code here on the screen if you did want to reach out directly to him. I think that covers the questions. I think you've clearly covered the talk in great detail, so I think that will conclude. So yeah, all is left to say is thank you very much, Dr. Chabok, for your time, and thank you everybody for joining the webinar today. There will be an email coming out to everybody with a short survey, if you wouldn't mind filling that out to everyone. And there's a couple more. There's a thank you just come in the chat box for you, Dr. Chabok. Thank you for a comprehensive talk. Is there anything you wanted to add before you go, Dr. Chabok?
No, thanks for your time and thanks for this opportunity. I hope it is helpful, and as you kindly already shared my contact details, I would be very happy to be contacted directly. And if I can be of any help, please don't hesitate to contact.
Thank you very much. Thank you for your time, and have a good afternoon, everybody.
Thank you. Bye-bye.